things that you should know about. You find it in almost every clinical setting. So it's very important to understand what epilepsy is. So start off by saying what is epilepsy. I'm sure you read on this. So if you have any idea what epilepsy is, you can tell us. Almost every clinical setting. So it's very. But before we even define what epilepsy is, who can tell me what a seizure is? So when we say a seizure, what does it mean? Anyone?
A seizure is the physical manifestation of the abnormal firing of neurons in the brain.
Okay. Any other opinion on what a seizure is?
I believe seizure is the clinical manifestation of epilepsy.
Okay. Do you have any more
Yeah.
views on what a seizure is?
Seizures are the abnormal electrical firing.
Okay. Any other?
A seizure is an abnormal electrical discharge in the brain.
Okay. So I think I'll go with this. All right. So basically, when we say a seizure, we are looking at the electrical activity of the brain. For every normal person, we have electrical activity that mediates some of these functions or cognitive functions. These electrical activity, the moment they become abnormal, they start firing at a rate which is not normal. We say the person has a seizure. So in simple terms, we are looking at abnormal electrical activity of the brain. That is a simple definition of a seizure. So abnormal electrical activity or firing in the brain. So how different is a seizure from a convulsion?
So a convulsion is a physical manifestation.
Anyone?
So a convulsion is a physical manifestation of a seizure.
Yeah, so the physical manifestation of a seizure is convulsion. So what is actually happening in the brain is a seizure. So someone, you can't witness a seizure. You can only witness a convulsion. So what is actually happening in the brain is a seizure. But what you see, which is the physical manifestation, is a convulsion. So let's take note of the difference. Now let's look at what epilepsy is. So we define a seizure, we define convulsion. So what is epilepsy?
An epilepsy is a hello. An epilepsy is a chronic condition characterized by recurrent unprovoked seizures.
Okay, so that's true. So the moment you talk about epilepsy, it's no more just one seizure. We are looking at recurrent, unprovoked seizures. And typically, it's not maybe today it happens within the next 5 minutes, it happens. So you say the person has epilepsy. So typically, the recurrent episodes, you should have it being 24 hours apart for you to say the person is epileptic. Mm. So we are looking at recurrent, unprovoked. It's a chronic condition characterized by recurrent, unprovoked seizures, often lasting more than 24 hours in terms of the duration apart. However, there are instances where someone can have one episode of a seizure, but that one episode, there's high chance that the patient will have recurrence. So the recurrence rate is very, very high. For such patient to, we say they have epilepsy. So it's one unprovoked seizure, but the probability of further seizures is high. And usually we are looking at the risk being more than 60%. So 60% or more in terms of the risk of recurrence. So if the risk of recurrence is more than 60%, then that patient also has epilepsy. Then the last bit of epilepsy diagnosis is people who are diagnosed with epilepsy syndrome. So epilepsy syndrome, they may have one seizure, but they may have other conditions that make up the syndrome. So maybe cognitive impairment, they may have other issues that make up the syndrome. But once you have that syndrome, even with one episode of a seizure, you are said to be epileptic. So let's take note of this definition. Any questions?
So please, can you come again with the epilepsy syndrome?
So for the epilepsy syndrome, there are a lot of epilepsy syndromes. The common ones, the Lennox-Gastaut syndrome, the Dravet syndrome. There are a lot of syndromes. So you may just have one episode of a seizure, but you have all the other conditions that make up the syndrome. So maybe you have developmental issues, especially the children that are born with special deficits. So they may have developmental issues in terms of cognitive impairment too. They may be cognitively impaired, and they may also have maybe episodes of seizure. But that episode may not qualify to be an epilepsy on its own. But because they have other conditions that make up the syndrome, they are known as epileptic because they have that epileptic syndrome phenotype. But they may have just one episode of a seizure, which is not enough to say they are epileptic if we don't have 60% recurrence. So the moment they have that syndrome, you say they are epileptic. So the definition of epilepsy, we are talking about recurrent, unprovoked seizures, usually 24 hours apart, or one unprovoked seizure, and the probability of further recurrence is 60% or more. Then the other definition is for patients who are diagnosed with epilepsy syndrome. They are also said to be epileptic. Is it clear? Hello.
Yes, please, sir. Thank you.
Hello.
Okay, all right. So let's talk about another definition, which is status epilepticus. So what does it mean to say someone has status epilepticus? Any ideas? Status epilepticus.
Doc, it refers to when someone has two or more seizures that are 30 minutes apart. There is no recovery between the two seizures.
Okay. Any other definition?
It can be a single seizure that will last more than 5 minutes without the patient regaining consciousness.
Okay. Any other, or someone has something to add? All right. So basically, status epilepticus, the first thing you have to notice is a medical emergency. So if you have a seizure that is not aborting within 5 minutes, you say the person has status epilepticus. So a seizure lasting for more than 5 minutes without aborting, or recurrent episodes of seizures. And these recurrent episodes, there is interictal loss of consciousness. So when you say ictal means a seizure. So interictal means the period between two seizures. So after a seizure, you have a post-ictal phase. So the post-ictal phase is usually where the patient is supposed to regain consciousness. But if the person is having recurrent episodes, and that recurrent episode, maybe you just had it, the next 2 minutes, there's another episode, the next 5 minutes, there's another episode. In between the episodes, that 2 minutes period, that 5 minutes period, if you are not able to regain consciousness, we say you have status epilepticus. With interictal loss of consciousness.
Sir, please could you kindly come again with the with that part with the ictal loss of consciousness?
Hello? Hello?
Hello.
Can you hear me?
Yes,
Please.
please.
Okay, all right. So we're talking about status epilepticus. So you can have a single seizure lasting for more than 5 minutes without aborting, or you can have multiple seizures in which the interictal phase, the patient does not regain consciousness. So the period between the multiple seizures, if the patient does not regain consciousness, you say the person has status epilepticus. Okay. Any questions? Okay. So let's look at the various types of seizures. So there are two main types of seizures. So it's either a generalized onset. So we have a generalized onset seizure. Then we also have focal onset seizures. And the last type, which is an unknown onset seizure. So basically it's three. So focal onset, generalized onset, then unknown onset seizures. So we define the seizure in terms of how it started. So for focal onset, we are looking at a seizure that is starting or originating from a particular portion of the brain. So when you look at the brain is divided into two main parts. You have the left hemisphere and the right hemisphere. So if a seizure is originating from an area or a focus within the left hemisphere, then you say the patient has a focal onset seizure. And now, as I was teaching you stroke, I mentioned that the left hemisphere controls the contralateral right side, while the right hemisphere controls the contralateral left side. So that's the opposite side. So if a seizure is originating from the left hemisphere, we see the manifestation on the right part. If it is originating from the right hemisphere, the manifestation will be seen on the left part of the body. So that's how focal onset manifests. So you realize that the patient may be having some jerky movements just on the right side of the body. It's not affecting the left. That should tell you it's a focal onset seizure. Another person could also have generalized onset seizure. So for generalized onset seizure, the seizure originates from both hemispheres. So it's a lesion, it could be a lesion on the left and also right, or you have abnormal electrical activity originating from both the left and the right. So typically, you realize that in terms of the physical manifestation, you see it on the left part of the body and also on the right part of the body. So that's how generalized onset seizures come about. For unknown onset, we know typically when someone has a seizure, it's the witnesses or the bystanders that are able to tell there's a seizure and all that. So they can go and meet the seizure and they can't tell where it started from, because maybe as at the time they got there is jerky movement on all parts of the body. So they can't tell whether it started on the left and progressed to all parts of the body, started on the right, progressed to all parts of the body, or they came to meet the patient after the seizure. So the patient had foamy, there's foamy mouth, you can see hypersalivation, bites on the tongue, urinary incontinence, fecal incontinence. All these are signs of a seizure. So just after the episode, they met the patient. So they can't tell where exactly it started, whether it's a focal onset or a generalized onset. So these category of seizures are known as the unknown onset seizures. So these are the three main types. Under the focal onset, you could also have three subdivisions.
Dr.
So
Sean,
the focal onset.
I'm not
Hello.
getting a clear difference between the generalized onset and the unknown onset.
Generalized onset, it starts from both hemispheres. Unknown onset, you don't know where it started from. Is that clear?
Yes, please. Thank you.
So for focal onset, you are saying you can have three subdivisions. So you can have focal aware seizures. So focal aware seizures. Then focal seizures with impaired consciousness. So focal seizures with impaired consciousness. Then the last bit is focal seizure evolving into generalized seizure. So a focal seizure evolving into a generalized seizure. So these are the three subtypes. So the old name of focal seizure is partial. So we used to term it partial, but now we don't use the term again. The new term is focal seizure. So it used to be partial seizure. Then under partial seizure, you can have simple partial, which is the aware seizure, focal seizure with intact consciousness. So that was simple partial. And the one with impaired consciousness was complex partial seizure. But now these terms are no more used. So we use the term focal seizure with aware consciousness, or focal seizure with impaired consciousness, then focal seizure evolving into a generalized seizure. Is that clear? All right, so who can tell me what a focal aware seizure is from the name? Anyone?
Say, please, with the focal seizure, the patient did not lose consciousness.
All right,
And the patient,
so focal aware seizure. So with that one, the patient is aware of his environment. He has not lost consciousness. So in terms of orientation to people, time and place, is well oriented. There's no loss of consciousness. However, the patient is having a seizure, and there's a focal seizure. So maybe the person is sitting there and can see the manifestations just on the right part of the body, but is well aware of everything that's happening. So that's a focal aware seizure. Then we can have focal seizure with impaired consciousness. So in this case, patient is having the manifestation on just the right part or just the left part, but the patient has lost consciousness. He's lost touch to people, place, and time. So that's the difference. Focal aware seizure, they're aware of their environment. Focal with impaired consciousness, they've lost consciousness. Then we could also have focal seizure evolving into generalized seizure. What this means is that the seizure may have started on the left part. So maybe the left part of the body was having the jerky movement. Then with time, it progresses to all parts of the body. So now it's not just the left part, but also the right part is involved. So it ceases to be a pure focal seizure. So we term it as a focal seizure evolving into a generalized seizure. And usually the generalized seizure that presents is the tonic-clonic. So it's a tonic-clonic episode. In terms of the generalized seizure that you have from a focal seizure. Is that clear?
Hello, sir.
Hello.
Yeah, please. So, is Jacksonian match as an example of a focal seizure evolving into a generalized seizure?
All right. So for Jacksonian match, you can have a seizure maybe on just the fingers. So it's a focal seizure, but it started just on the fingers, and it can evolve to the whole arm, but it's at the same side of the body. So that one, Jacksonian march, is not a generalized seizure, but it's a focal seizure starting from the fingers, maybe the first minute. It's just the fingers that are having the jerky movement. But with time, you realize that the whole arm is having that jerky movement. So it's an evolving focal seizure. So it hasn't evolved into a generalized seizure, but it's still focal. So that's what we term Jacksonian march. So it's a focal seizure, but hasn't progressed to generalized.
Okay, thank you.
Okay. Any other question? All right. So let's talk about the subtypes of generalized seizure. So what are some of the subtypes that you know?
Tonic-clonic seizures.
So you have tonic-clonic seizure. What again?
Absent seizure.
So absence seizure. What again?
Clonic.
Myoclonic
So myoclonic seizure. What again?
Atonic.
Atonic seizure. Okay. What again?
Clonic
Tonic
seizure.
seizure.
Tonic seizure. What again?
Clonic seizure.
Clonic seizure. Okay. Any other? I think we are done, right? So these are the subtypes of generalized seizure. So we can have a tonic seizure, a clonic seizure, a tonic-clonic seizure, atonic seizure, myoclonic seizure, and absence seizure. So these are the various subtypes that we can have. So let's look at them one after the other. So let's talk about tonic seizure. So when we say tonic seizure, what does it mean? Anyone?
It is associated with rigidity in the muscles and the limbs.
Yeah, so this is a type of seizure characterized by sustained muscle rigidity. So it's a type of seizure which is characterized by sustained muscle rigidity. So the tonic phase is rigidity. Mhm. So you wouldn't see the jerky movement, but the patient is just rigid. Mhm. So during this time, the patient is unconscious. So let me make it, let me say that for generalized seizures, they usually lose consciousness. Unlike focal, where you can have focal aware, then focal with impaired consciousness and all that. When it comes to generalized, there's usually loss of consciousness. So for tonic phase or tonic seizure, we are saying that this is a type of seizure characterized by sustained muscle rigidity. Okay, what about clonic seizure? Anyone to tell us what a clonic seizure is?
And please, I think the clonic is when there's jerking movement of the whole body.
So basically, for clonic seizure, we are looking at seizure characterized by sustained muscle contractions or jerky movements. So this is where you start to see those jerky movements, the typical jerky movements we see. This is how it manifests. So for clonic seizure, it's characterized by sustained muscle contractions or jerky movements. All right, what about tonic-clonic? Tonic-clonic. We've talked about tonic, we've talked about clonic. So when we say tonic-clonic, what does it mean?
Alternating episodes between muscle rigidity and muscle contraction.
Yeah, so this is a type of seizure which is characterized by sustained muscle rigidity, which is the tonic phase, interspersed with the clonic phase, which is the jerky movement. So you have alternating tonic and clonic phase. So that's a tonic-clonic seizure. All right. What about atonic seizure? Atonic seizure.
So with the atonic, the individual loses their the tone in the muscle. So they just fall to the ground like there's nothing holding them. So the muscle just loses its ability to contract or relax, and they just fall to the ground.
Exactly so. So for atonic seizure, basically it's characterized by loss of muscle tone. So you lose muscle tone, and typically these patients tend to fall. So seizure characterized by sudden loss of muscle tone, and these patients are prone to falls. So that's atonic seizure. Myoclonic seizure, what does it mean? Myoclonic seizure. Anyone to tell us myoclonic seizure?
Myoclonic seizure is characterized by sustained involuntary muscle twitching.
Exactly. So here you are looking at involuntary muscle twitching. So this is characterized by sustained involuntary muscle twitching. All right. So myo means muscle. Clonic, you've already talked about jerky or muscle contraction. So here you are having sustained involuntary muscle contractions or jerky movements. All right. And the last one, absence seizure. Absence seizure. Anyone?
There is a
Anyone to tell us?
sudden momentary loss of consciousness for a few seconds.
Yeah, so here, absence seizure usually affects children. And basically what happens here is the sudden momentary loss of consciousness. It's as if someone has casted a spell on you. So that sudden momentary loss of consciousness for some few seconds. It doesn't take long, some few seconds, and you are back. And usually not associated with any post-ictal confusion. So after the episode, the patient is back to the normal activity. There is no post-ictal confusion. So that's absence seizure, sudden momentary loss of consciousness for some few seconds. So all these are subtypes of the generalized seizure. So if someone presents with a seizure, the first thing you want to know is what type of seizure is it? Because the type of seizure can affect how you manage it. And even in terms of the history can even give you an idea of the type of seizure. But they tell you, oh, we're just talking to him and all of a sudden he went off for some few seconds and he came back, we were conversing. So you may think of absence seizure. They tell you were just walking and all of a sudden fell. You think of likely atonic because there's lots of muscle tone and they are prone to falls. They tell you, oh, it started with rigidity and all of a sudden we started seeing the jerky movement. So there are two phases to it. So there was a rigidity phase and there was a jerky movement phase. So that's a tonic clonic. If they tell you it was just rigidity throughout, then you are thinking of a tonic seizure. If it's just jerky movement throughout, you think of a clonic seizure. If they tell you it was just on the right part of the body, the left wasn't involved, you think of a focal seizure. If they tell you it started on the right, but it ended up affecting all parts of the body, think of a focal seizure evolving into a generalized seizure. So all these are ways that you try to elucidate whether it's a focal, generalized, and a subtype that you have. Any questions?
Yeah, sir. Please with the myoclonic.
Yeah.
Is it that all the muscles will be jerking, or just one muscle part of the body like will be jerking?
So most of the times you have majority of the muscles having that jerking movement. So it's not localized to just a portion. So you have a generalized muscle contraction or jerking movement.
Sir, please, what's the difference between the myoclonic and clonic? Is it a time? What exactly?
So here, myoclonic, we are just looking at the muscle. So there's twitching of the muscles. Whereas clonic is just contractions or jerky movement of that part of the body. So the whole limb may be jerking. So the whole hands may be jerking. But this one is just muscle. It's not the whole limb.
Oh, okay, thank you.
Any other
Dr.
questions?
With the atonic seizure and then the absence seizure, you see, with the absence, they are losing consciousness, so they are also likely to fall. So, what's the main difference? How would you differentiate between them? Is it the consciousness level or?
No, it's the muscle tone. So you can actually check for muscle tone. So muscle tone is basically what is helping you keep your balance. So atonic, they lose that muscle tone and they are falling. Absence seizure is like the person is not falling all right, but they just went off for some few seconds. They are like talking to the person and within some few seconds, 2-3 seconds, the person is like off. He's not aware of whatever is happening at that point, but he's not lost the muscle tone for him to fall, but he's just off.
Okay, I understand. Thank you.
Hello,
Okay.
sir.
Hello.
With the clonic and tonic, those seizures, is there any particular is there any characteristic way for they are falling? I think some of them they fall forward, some of them they fall backward. I don't know if it's true.
For which of them?
For the tonic and the clonic. Like if it's tonic, there's a way they fall, and if it's colonic, there's a way they fall.
I'm not aware of that. Any other question? Okay. All right. So let's look at some of the triggers of seizures. So basically, there are certain things that can precipitate seizures. Remember in the definition, we talked about epilepsy as recurrent, unprovoked. So that unprovoked there, it means that there are certain provocating factors. So before you say someone has epilepsy, you have to rule out provocating factors or precipitating factors. So there are certain things that you should rule out first before you say the patient has epilepsy. So what are some of the provocators or the precipitating factors that you know about?
Hello, sir. So we have electrolyte imbalances, hypoglycemia, infections, trauma can cause it, and also in kids to fever, and also cause seizures.
Okay. So the provocating factors, you mentioned electrolyte imbalance, which is true. So common electrolyte imbalance, that does seizure. What are some of the common electrolyte imbalance?
Hyponatremia, hypernatremia. So I think hyperkalemia too can also do that.
Okay, so it's usually hyponatremia. Hypernatremia can also do that. Hypocalcemia. So hypocalcemia and hypomagnesemia. So these are usually the usual culprits. So for sodium, hyponatremia, hypernatremia, then hypocalcemia and hypomagnesemia. These electrolyte imbalance tend to cause seizures. What again? So you also mentioned some metabolic factors too. So hypoglycemia and hyperglycemia. So someone with DK can present with a seizure. Someone with hypoglycemia can also present with a seizure. So it doesn't mean the person is epileptic because these are provocating factors. So before you say someone is epileptic, they can have recurrent episodes of seizures. But if you go in there and there is hyponatremia, you can't say the person is epileptic because that's a provocating factor. So you have to correct the hyponatremia, the hypoglycemia, the hypernatremia, and all that. And you watch out for whether there will be these episodes that you were recording prior to the correction. So if you are still recording that, then possibly the patient may be epileptic because the provocating factors have been ruled out. But if you go there and there's hypoglycemia, hypernatremia, hypocalcemia, and all that, these are all provocators. All right, what again?
Infections.
So infections like what?
Like meningitis, cerebral malaria.
Yeah, so meningitis, malaria, encephalitis, all these can cause seizures. All right, what again?
Autoimmune conditions.
Hello. Hello. Is someone talking?
Eclampsia.
Okay. So yeah, talking about pregnancy induced seizures. So pregnancy can do that. So someone with preeclampsia having a seizure, you think about eclampsia. So the patient is not epileptic, but as a result of complications of pregnancy, 20 weeks into gestation, evidence of hypertension and proteinuria, then seizures, doesn't mean they're epileptic. That's eclampsia. So for such patients, the management is different. Usually the seizures will resolve some weeks after the pregnancy or the patient has been delivered. All right, what again?
Missed medication.
Yeah, so missed anti-epileptic dose. So if this patient is already epileptic and they miss their anti-epileptic dose, it can precipitate a seizure. Okay, any other?
Yeah.
Autoimmune
Alcohol
conditions.
withdrawal.
So I think someone was mentioning dehydration. So dehydration too can precipitate seizures. Any other?
Lack of sleep, anxiety, stress, and extreme fatigue.
Okay. All right. So all these causes stress to the body. So anxiety, anger, emotions, swings in emotions and all that. All these can cause seizures. Any other?
Medications like fluoroquinolones,
Yeah, so medications like what?
some of the fluoroquinolones, and then pethidine in sickle cell patients.
All right, so that's that lower seizure threshold. So fluoroquinolones, pethidine, what again?
Imipenem.
Yeah, imipenem. Any other?
CCAs.
Yeah, tricyclic antidepressants. What again?
Antibiotics.
Isoniazid. What again?
Metronidazole.
Yeah, Metro 2 can do that. So there are a lot of medications that can do. So lithium, theophylline, come to the antipsychotics to clozapine. They can all induce seizures. Antibiotics, you have your fluoroquinolones, you have your imipenem, even the beta-lactam antibiotics can also do that. The cephalosporins too, especially the fourth generation cephalosporin, cefepime, can also do that. And then you also go to some other miscellaneous medications, your pethidine, tramadol, analgesics. So there's a tall list of medications that tend to do or reduce the seizure threshold. So someone who is already epileptic, you want to be cautious with some of these medication. Or if the patient is on 2 or more of these medication, the risk of having a breakthrough seizure is also high. So you always have to be on the alert for some of these things. Okay. So
Dr.
the
Ishan, please,
hello.
so if a patient is on any of these drugs and he or she ends up having a seizure, what goes of the drug or what?
So ideally, if there is an alternative, you want to switch to the alternative. But if there is no alternative, then you want to optimize the anti-seizure medication for the patient. So, for example, maybe you've done culture isolated Klebsiella sensitive to imipenem. The person is epileptic, but needs the imipenem to treat the infection. And you know that the moment you start imipenem, it's likely that the seizure frequency may increase. It's not always the case. Sometimes you start and you wouldn't see any increase in the frequency. So if you start and you are seeing increase in the frequency, you optimize the anti-epileptic medication of the patient. But if it's showing sensitive to meropenem, sensitive to imipenem, but the patient is having seizures, you will rather want to do meropenem in that case because it has less risk of causing seizures compared to imipenem. So you always have to weigh the options. If there is an alternative, switch. If there is no alternative, you give it and you monitor. If it's increasing in frequency, then you want to optimize the anti-epileptic dose.
Does this intervention apply to non-epileptic patients as
For
well?
non-epileptic patients, they are not epileptic. So for them, they usually wouldn't have seizures unless you are using maybe 2 or more of these medication. That makes the risk higher. So, and someone who is not epileptic will take Cipro. I'm sure most of us have taken Cipro and we never had seizures. So the risk may become higher. Maybe if you are on Cipro and you are taking imipenem or you are taking any other agent, and you also have maybe an underlying condition like these are some of the instances that makes the risk higher in non-epileptic. But for epileptic, their threshold is already low. So anything that you put them on can further lower the threshold and make them start having seizure. But normal patients, your threshold is very high. So unless there's other multiple factors, you wouldn't have a seizure just like that.
Thank you.
Dr. Aisha, please, I have a question as well. With the trauma being a precipitating factor for the epilepsy, let's say that a patient is not a known epileptic patient and is a very normal person, but there was an accident where he probably hit his head on something and he even had to come through the A&E and all that. And you manage all those other underlying conditions, but afterwards you notice that this patient keeps on coming all the time now for the management of epilepsy. And let's say you were the one following the case, and when you took the history, oh, it hadn't happened to him before prior to the whole accident and all. Does that make trauma now I don't know, but does it mean the person is now an epileptic patient? And if trauma was a provoking factor, then it means it was a trauma that provoked it. I don't know if I'm asking the question, but I think I've heard of cases like that too, where they are like the patient was okay, but after the accident, this means the patient has now become epileptic for life or something. Yeah, that's my question.
Okay, all right. So in the brain, we have what we call areas that are epileptiform focus. So these areas, you may not be epileptic, but if you should have any lesion within those areas, your likelihood of becoming epileptic is high. So usually the cortical areas. So the cortical areas are epileptiform focus. So if someone has a lesion or trauma or anything affecting the frontal lobe, the occipital lobe, the temporal lobe, and all these lobes. These are cortical areas. So if it's affecting these cortical areas, the likelihood of the patient developing epilepsy is high. So maybe they are not epileptic, but they had a lesion in the frontal lobe, occipital lobe, temporal lobe. They can become epileptic. Then there are some subcortical areas like the thalamus. So the thalamus too, someone can have a lesion within the thalamus, may not be epileptic, but because of that structural lesion, the patient can start having recurrent episodes of seizures. So after trauma, infection, so we have what we call causes of seizures, and we have what we call precipitants. Some of the causes are precipitants at the same time. So the examples that we were mentioning, if the person is already a known epileptic, there are certain things that can precipitate seizures in that known epileptic. So these are usually referred to as seizure precipitants. So the person is already a known epileptic, but there are certain things that can precipitate episodes in that person. Whereas the causes are, the patient may not be epileptic, but because of these things, it can cause seizures in that patient. So epileptic can just be angry, because of the anger, develop a seizure. So that's a precipitant in a known epileptic. So the person is a known epileptic, but because there was a change in mood, either the person is angry, either the person becomes sad, either there's frustration, all these can precipitate seizure in a known epileptic. You could also have, so the person has not slept for a number of hours. Because they've been sleep deprived, they can start having seizures. Then fatigue. So when they are so tired or they are exercising, so anything that's causing strenuous activity, causing fatigue, can precipitate seizures. In a non-epileptic, it can precipitate a seizure if they do not take their anti-epileptic dose. So missed anti-epilepticants. So fever, missed anti-epileptic dose, stress, sleep deprivation, and all that. Whereas the cause have a direct causal effect. So you can have infections and develop a seizure in a